righty, good afternoon, folks. Welcome in the virtual world. We thank you for joining us. We bring to you this conversation today as part of an extended series that's sponsored by the Center for the Advancement of the Humanities at Marquette University. That particular series is titled Between Historical Inequalities and Future Challenges. This is the third installment. And today we will have a very important conversation regarding communities of color, vaccination, and the historical injustices of medicalization. So we're going to cover a lot of ground. Sit tight with us. We are all pretty savvy with the Zoom panel discussion. So settle in, grab some lunch, grab a beverage or two, and let's have this important conversation. My name is Robert Smith. I'm the Harry G. John Professor of History and Director of the Center for Urban Research Teaching and Outreach at Marquette University as well. And we have a couple of other partners we want to highlight. We are collaborating today with UW-Milwaukee's Institute for Systems Change and Peace Building and the MKE Black Grassroots Network for Health Equity. So we brought together some really important thought partners and folks who are on the ground grappling with these really important issues. And I don't want to do too much more of an introduction because I want to get ourselves into this rich conversation. We've got some great panelists who are going to give us the necessary thoughts and ideas and curiosities about how we are continually to be challenged by COVID-19, and then hopefully we'll continue to talk about ways to move forward. We are joined today by Dr. Abiola Keller, Assistant Professor in the College of Nursing at Marquette, and Dr. Samantha Mayer, Assistant Professor in the English Department at Marquette University, as well as Walter Lanier, Founder and CEO of the African American Leadership Alliance of Milwaukee. We were going to be joined by Erica Sinclair, Founder and CEO of Health Connections. She's unable to make it today, and we certainly will miss her, but she has provided some really rich content that we'll share with you in her absence today. Folks, let's get started. And I want to give our panelists a chance to get warmed up as we move into this conversation by allowing you folks to introduce yourselves and tell us a little bit about how your work and your interests connect either to the vaccine and pandemic or to public health more broadly. And so how about we start with Dr. Keller. Dr. Keller, can you lead us into this? Just tell us a little bit about the work you do and how your work either connects to the vaccine and the pandemic or public health more broadly. And then we'll go with Dr. Mayer and then have Attorney Lanier wrap us up with some introductions.
Great, thank you. I guess it's good afternoon, everyone. Thanks for having me as part of this conversation. I'm looking forward to this. So as Rob mentioned, I am an assistant professor in the College of Nursing at Marquette University. My research focuses on issues related to health and health equity for African American women, particularly those who are caring for older adults. And so that has been a very critical and vulnerable population during this pandemic. In addition to that line of work, I also teach on campus. And so I teach in an undergraduate course that helps our students transform into thinking about health, not just as being things that are formed within the healthcare system, but really thinking about how the social determinants of health help us to produce and to protect health. And then I also teach epidemiology, which is focused on understanding how diseases spread through populations. So that has been a very interesting course to teach during this pandemic. I'm also currently serving as the chair of the health working team for Near West Side Partners. And so that team is focused on advancing and protecting health and health equity for our residents of the Near West Side and also for our employees who work within the Near West Side borders. So that's a little bit about me and what brings me to this space.
Dr. Keller, you're going to need to drop your CV into the chat so we can follow all that. But yes, we will certainly engage many of your interests and areas of expertise. Dr. Mayer, please tell us a little bit about yourself.
Hello, everybody. Glad to be joining the discussion and coming from the arts side of things. I'm an assistant professor here in the English department, and my focus is on Native American literature. I'm a Dakota language advocate, and my background is Dakota and Assiniboine. And I would say, the perspective I'm bringing to the table is so much of our Native American literature engages with histories of injustice and oftentimes health and medical injustices, but also disease and pandemics that we've faced in the past. And certainly the Native community has been drawing on our memory of these earlier times as we faced the COVID-19 pandemic. And it's also something that when students are in my class, whenever I can, I address the issue of medical history and injustices, because it's an area that many students have not encountered before. And when they encounter it in stories to understand Native American literature and stories, they need the context of policies and things that have happened in the past. So I'm often bringing those into class. And I'm also very aware oftentimes that I have students who are going into various medical fields who may be coming in to take a literature class to fill one of their requirements. But oftentimes they're surprised to find these connections and to think about some of the headlines of recent years and how they connect to these historical injustices and better understand why there are disparities in the statistics coming out of COVID-19 and how COVID-19 has affected different communities. So,
thank you so very much. Yeah, you know, this is so critical, and I'm so glad that we have the humanities, the Center for the Advancement of the Humanities sponsoring this, because we know the importance of interdisciplinarity broadly. We know how important it is to look at a particular issue from multiple perspectives. And one of those core perspectives is working with folks at the grassroots level who are directly engaged. And so this is wonderful. Shout out to the Center for the Advancement of the Humanities for bringing us together in an interdisciplinary way. Brother Pastor, how you doing over there?
I am doing well. It is a blessing to be in the space and sharing with these dynamic intellects and dynamic experience. So I'm grateful for the opportunity. My name is Walter Lanier. I wear several hats. I'm not the founder, actually, but the president and CEO of a relatively new organization called the African American Leadership Alliance, Milwaukee. Also a pastor of the Progressive Baptist Church. How do I come into the space? I think how is my experience in the place that I labor are intersections of professions, systems, and community. The intersections of professions, systems, and community. Being both a pastor and a lawyer and an educator, I worked at MATC for 13 years. And always looking at how the large systems have an impact, particularly where there's open access on community, and how can we do better. So in addition to being one of the people that helped found and facilitate the Milwaukee Black Grassroots Health Network, I also worked, as I said, at MATC for 13 years. That's open access. That's 30 to 45,000 students, cross-cultural, cross-economic strata coming into an institution. How do we serve them with excellence? I also chair the Milwaukee Health Services Board, MLK Heritage Center, where Dr. Tito Izzard is the president and CEO. And that's open access healthcare. We get about 30,000 visits per year. And so how do we deal with that system, that bureaucracy, and make open access effective for a broad range of people? Also, I chair MICA's Religious Leaders Caucus, MICA's Milwaukee Inner City Congregations Allied for Hope. We'll call that open access religion, I guess. But how do we look at systems and bring resources from systems to community and community to systems in an effective way? Last thing I'll say before we jump in. So the Black Grassroots Health Network actually grew out of the beginning of COVID, where myself and a couple of other people, Jeff Roman, who's now the director of the Office of African American Affairs / Equity for the county, Quentin Cotton, who was pursuing his doctorate in public health. We wrote an op-ed for the Neighborhood News Service about the ineffectiveness of the systemic response to COVID way back in April, and we laid out a framework that we thought would make sense. But the point is, this was coming from community saying, hey, systems, we need to do better, and here's how to interface effectively with community. out of that was birthed the Grassroots Health Network, and we'll talk about that a little bit more. But all things about bringing resources closer to community and vice versa, that's where I try to spend my time and my labor.
Thank you very much. There's one other individual on the call who will try to remain quiet and not join us. I might actually call on him though, periodically. He's really been instrumental in putting this series together. He's doing it all. He's running tech support. He's flying the plane. He's baggage handler. He's everything. Jorge Montiel. Jorge, will you just say hello to the folks real quickly?
Yeah, so glad this is happening and to be part of it and to be supporting it. I'm Jorge Montiel. I'm the graduate assistant for the Center of the Advancement of the Humanities, and I'm really happy to be here with all of you, and so excited to hear you all.
Thank you very much. Thank you very much. I want to say, as we get into this conversation, there is one particular shout out that I like to offer, and that's Go Bucks. We are in the playoffs. Let's not forget about how important that playoff run last year was for the city, and in some ways for our emotional health, to have something to cheer on and be excited about. So Go Bucks. All righty, let's get into it, folks. We're a couple of years in now. We have seen and been places with this pandemic that in many cases we don't want to revisit, but it's still with us. Can we talk a little bit about vaccine rates? Where are we with this all too important conversation around vaccine rates? And then we'll get into some continual issues and challenges, but let's get a little bit of data and some ideas about that. Dr. Keller, can you lead us into this conversation in this portion of our panel? Where are we with this vaccine issue?
Sure, I'm happy to do so, Rob. So in looking overall, I'm going to focus on Milwaukee County because I think that represents the interest that we have. In the data that's updated weekly from the county, we're looking at about 62% of our residents who have at least one dose of the vaccine. And as many people are aware, in order to be fully vaccinated, the recommendation is that you actually have 2 doses. And then up, for adults, there's a third dose as a booster. So, I'd say that there's still work to be done. And then as we look at groups by, race and ethnicity and social identity, we look at for our white residents, 65% of them have 1 dose, and about 61% are considered fully vaccinated. For Latinos, we're looking at about 62% that have 1 dose, around 55% that are fully vaccinated. For our African-American population, there's definitely a lot of work we can be doing that we still need to be doing there. So about 48% have 1 dose and 43% are fully vaccinated. And as we look at our Native populations, and that's an interesting data there. So within that group, about 79% have received at least 1 dose, and 72% are fully vaccinated. And when we look at the Asian population within the county, 78% have received at least 1 dose, with about 68% being considered fully vaccinated. So definitely, some groups are doing better in terms of vaccination rates than others. But across the board, there's still work to be done.
Great, thank you, Dr. Keller. Can you let folks know where you are extracting, so that at the very least they have heard from an expert where we should go get accurate information?
Yeah, so Milwaukee County actually has a whole host of data that's available on their website as part of their COVID-19 surveillance program. So you can look at not only the number of new cases, how hospitalizations are doing, but also the vaccination data. And you can look at things by all the way down to by zip code as well. So if that information is available through the Milwaukee County website, and right on there it says vaccinations and testing, and this is also the COVID-19 dashboard, which is a great visual of all of this information.
Yeah, absolutely. Thank you very much. Attorney Lanier, Dr. Mayer, do you all want to jump in at all and offer any commentaries and thoughts about vaccine rates across communities of color based on your experiences and the folks you engage with? Any thoughts to help amplify and make even more sense out of that data?
Maybe I'll just jump in quickly and talk a little bit. So I just to add another resource, which I think the Gerald L. Ignace Indian Health Center has been doing, putting great resources on their website, and then also doing a YouTube series of town halls. You know, they're transitioning it now as, you know, pandemic is changing. Perhaps we're moving into an endemic, but they've been putting out great information. So that's where some of my information comes from. And then also, I think they're drawing on the same resources here and the same statistics. But I will say the high rate of vaccination in Indian country, I think thinking of the Native population across Wisconsin and then more broadly across the United States, follows this line in general. I think we have a really nice high vaccination rate here in Milwaukee, but you know, that gets a little bit lower as we move out. But part of the reasoning for that is because I think Native people have a long memory of dealing with disease and pandemic, and there was a big push in Native country to get vaccinated, take care of the community. There's still work to be done across, and especially in getting the boosters. I think I see lagging in the data there for Native populations, but I think we'll talk more about it a little bit later. But I think the way that COVID spread, with the Navajo Nation in particularly being an incredible hot spot early on in the pandemic, really drew Native communities to wanting to be vaccinated and pushing this out to the community.
You know, Dr. Mayer, actually, can you stay with that? Can you tell us what you're alluding to? And then I know Attorney Lanier, you wanted to jump in. We'll come right over to you, but please continue, because I think folks are needing to hear what you have to share on that.
Yeah, if we think back to the early days of the pandemic 2 years ago in the spring, you know, the biggest hotspot right out of the gate, at least in the United States, was New York City, of course. But then right on its heels, we saw this major outbreak on the Navajo reservation. And it became, you know, the hotspot for COVID-19 spread in the country. And at that time, we didn't have these resources. We didn't have, you know, the vaccine. And I think I'll just speak personally, when everything shut down and we started hearing about COVID-19 and this new outbreak and pandemic, a new disease, my first thought and much of the reaction in Native communities was a worry for our elders. And in Native communities, as with many communities, we cherish our elders, but also, you know, Native communities are continuing to reclaim and rebuild things like our indigenous languages, which were frankly, you know, under attack in the late 19th century and into the 20th century with different assimilation policies put forward. And so as Native people continue to reclaim, rebuild, revitalize our languages, our songs, our traditions, our cultural knowledges, it is our elders who are those knowledge keepers. And so immediately knowing that they were vulnerable, I think put everyone in this mind frame. And then just to address sort of the Navajo Nation, why was that the next biggest outbreak? When you think about, New York is a little bit obvious. It's highly population. You have lots of people traveling in and out. Why a very sort of rural, widespread reservation in the Southwest is the next major outbreak and was the hotspot for a while? Well, a lot of that has to do with what we're talking about today, which are these health disparities in healthcare and access. And then when you're specifically thinking about the Navajo Reservation, you're talking about a place that has a continuing water resource issue, the inaccessible, no access to fresh water. And so when you're asking people to, as part of prevention, to wash your hands and to stay away from each other, this is very hard to do when you're in a situation that is dictated by sharing resources, gathering resources at gathering spots, and not having some of those preventative measures. There's a lot that goes into that, and we get into issues of climate change and water resources when we think about the Southwest, and we could just go on, but it's interesting how so many of these factors are connected and have become visible in the course of this pandemic.
Absolutely. Thank you so very much for that. And we're going to ask you to give us a little bit more history too. So setting that contemporary context is very valuable. Pastor Lanier, why don't you jump in and offer some other commentaries for us as we think about vaccine rates and the like?
Yeah, lots of thoughts. When we, in April of 2020, as I mentioned, myself and Jeff Roman, Quentin Cotton, Erica Sinclair were involved in some things. Host of others, other people were doing it too, did this op-ed and identified some areas of significant concern around response. And it's awesome and admirable, the number of institutions that jumped in, IGNACE, the FQHCs, civic response teams. But in the context of health disparities, as excellent an effort as we put forth, we're still gap filling. And as I've talked about this over the past 2 years, we should never forget that, because there's the health disparities that were in our systemic, and there are gaps in the system. And so some of these outcomes and the continuing disparities were just incredibly predictable because of the systemic gaps in the first place. So these phenomenal people came in, phenomenal orgs. Our work was pretty solid. You mentioned IGNACE's, I mentioned the FQHCs was solid work, but we're still filling gaps that really a system should have been in place in the first place. And it was always hard, always going to be difficult, if not impossible, to catch up. So that's one kind of mega point I just want to lift, is that the ground of the community mobilized swiftly and moved in and filled as well as it could with PPE. There was a season and time where my church, where I was pastoring, we were like a distribution hub for a season for masks early on in the process, because we were able to get some. We actually got them from somebody outside the state of Wisconsin, which is great and awesome. But that was us doing it as volunteer people who have passion for community, and our capacity was maxed out. So we shouldn't miss that out when we talk about disparities then and now, is that we're still filling gaps in systems that should be there. The other thing, when we talk about vaccine disparities, I have two thoughts. One is the conflicted relationship that we have with systems. On the one hand, for it to be as effective as it needed to be from the system, from healthcare systems, from health departments, from the federal government. I'll set that to the side because that was completely blown by 45. I'm not going to set it aside for long because that's about information credibility. So on the one hand, we really needed systems to be excellent. But on the other hand, we have a wary relationship with systems, conflicted, Tuskegee experiments, sterilization, infecting blankets with the Native Americans, lead in the water. So we've had the whole medical apartheid book. So I've got a conflicted relationship with systems. I need you on the one hand, but on the other hand, I don't trust you. And so that made it tough. And then third, the systems were just not effective. Dr. Izzard, who I mentioned a couple of times, used to say, and still continues to say, what really needed to happen is there needed to be a FEMA-like response, to the pandemic in our cities, and it just didn't happen. And a rapid infusion of PPE, a rapid infusion of accurate information. And once we got behind, it was always difficult to catch up. And then lastly, perhaps most importantly, with 45, the previous president, we already had a combustible and chaotic environment. And I'm probably going to be kind no matter what I said, because I could say it in a lot worse ways. But I'll say it this way. There was a complete damaging and breach of the credibility of information. And then once that was breached, it took me, I like to simplify things, being a lawyer and a pastor, contrary to public belief. Simplify. Teacher at heart is this destruction of what is credible information. And once that happened, then one could get information from anywhere. Anybody was an expert. Anybody with Google was an expert. Anybody with a conspiracy theory was an expert. I remember early on in Milwaukee, for example, was disproportionately hitting the Black community, and so that was a conspiracy theory. Then there was another narrative that's saying, well, Black people can't get it because on the continent of Africa, it's not hitting over there. Then there was a season where we had the conspiracy theory that it was all about 5G. And so all of that was manifesting, and because there was not a FEMA-like response, because there was not a credible source of information from somebody's bully pulpit, then we were kind of left to fend for ourselves, to determine in some sense who was credible and who to follow. And then the last thing I want to mention is, and I don't know if this is the case, it's just my thought, based on what ultimately happened in Native American communities, based on the data that was provided. And then I think about my own leadership of my church. Early on, I could see all of the things that I just talked about, particularly the lack of clear, credible information. And so I said to myself, my God, I always want to help as much community as I can, but I only have influence there. Here I have a bully, a literal pulpit, people who will listen primarily to me. So I got super hyper focused on getting clear, accurate, credible, consistent messages to the people over whom I had responsibility for leadership. And we lost very few, single digits to COVID. And so we were able to have a singular message in that community. And I wonder, don't know, but I wonder if in the Native American community, because there's fewer message sources or a place of primary messaging, if that helped with credibility for the community, for the collective to move forward with vaccinations. So those are some of my thoughts.
Yeah, thank you so very much, because you really laid out, for the folks joining us today, we wanted to talk about vaccines, certainly, and where we are with vaccination rates, but we also wanted to get into these very issues. How do we get to a place where conspiracy theories seem to be more accepted and welcomed than actual fact?
Rob, if I could jump in.
Yeah, please do. Yeah. Absolutely.
So I do think, it's important to lay a little context, both to what was said in terms of why did the response seem to be better in some places, or at least have a different effect in places? And I think that it's important to think about this idea of where did we start? And I think the information we're going to talk about, some of this historical issues, leads to, where we start. If you think about it in terms of a starting line, right, there's some communities that are starting further back just because of things that have historically happened. And those are, communities of color. And so when the response to COVID-19 was launched, it was what, in public health, we would talk about as it was an equitable, or it was an equal response, right? So the response was every community was treated the same. That disregarded the gap in the starting place between some communities and others. So yes, everyone moved forward, but that gap remained. And in some cases, the gap got bigger. What we actually needed and how we need to move forward is thinking about things from an equity standpoint, meaning that not every community needs the same thing, but what we want to do is to get everybody, give them the opportunity to advance their health and protect their health as much as possible. And that means that we might have to do something, and we will have to do something differently in each community. So I think it's important to keep that context in mind as we talk about, well, why is that? How did we get to this place where we started off at a different starting point?
Great. Thank you so very much for that, Dr. Keller. Dr. Mayer, did you want to jump in at all and offer any other comments? This is all really good. Folks who are joining us, we've got a plan of action for the panelists are already executing our plan of action. So you all just keep running with it. Dr. Mayer, go right ahead.
I would just jump in and second what Dr. Keller is saying, in the sense of this, to me, what has happened with COVID-19 and seeing these disparities in the statistics and in the actual experience of COVID writ large, sort of speaks to our history. And we need to connect those dots, because if we don't, if we just share these statistics and, for instance, we went over, and again, I'll speak to Native populations, city of Milwaukee, 72% fully vaccinated, so highest vaccination rate, and yet as percentage-wise per population, highest COVID deaths. So we need, we can see these statistics and go, that's interesting. But if we aren't well versed in history, which we don't tend to be, especially with these hidden histories and suppressed histories about, white supremacy and racism and how this worked in healthcare and how it works in our bodies, we are very liable to sort of actually inculcate these ideas about race and biology if we don't understand the historical link. And the reason that, for instance, in the Native community, you have, a higher percentage of people with those comorbidities that might make a COVID case be deadly. I just think making these links to our histories and to our health access, our current access, are essential for us to be able to make sense of why COVID hits differently, and then also why it's an uphill climb in some cases to get people vaccinated. And I think, the point about our lack of leadership at critical times is monumental as well. I can say for the Native community, I see our high vaccination rate as twofold. I think part of that was the initial push of the vaccines and the fact that Native nations have a government-to-government relationship with the federal government, and so had a little bit of a different rollout than other sectors. And then also within the community, the memories and the push to the sort of narrative about protecting our communities and our elders was very strong. That's not to say that there isn't any of that mistrust of the message we were getting and the government in general, and these sort of large scale efforts. There certainly is that, and there's reason to have that. So lots of good connection points in the discussion.
Yeah. Thank you all very much. I'm going to stay with the history just a little bit more, because we've seen such a remarkable increase in anecdotal comments about racist public health practices, which on the one hand speaks to some important awareness of that history. Of course, a lot of it also isn't particularly accurate. So there's a tension there. Can you all just share some thoughts and offer maybe an example or two of historical realities that have really damaged our capacity to believe in those systems. Walt, you mentioned some of this in some of your earlier comments. Dr. Keller, you've alluded to it. Dr. Mayer, you've really outlined it. Let's give our listeners just a little bit more of a concrete connection between historical injustices and where we are today, even if you have one or two examples. And for example, in looking at the history of African Americans overwhelmingly were a Southern population prior to what we refer to as the Great Migration, where healthcare options were extraordinarily limited. And so folks had to really rely on what they had learned along the way around healthcare that was very much homegrown. Some of that still works, some of it may not work. We have heard the Tuskegee experiment brought up in more ways than I had ever imagined it would be in these moments. So offer us just a little bit of some of those concrete historical connections so that maybe we can kind of begin to dispel some more of those myths, but certainly recognize where folks are coming from with their concerns. Anybody want to jump in on that? I know it's big. I know I just asked the toughest question.
Well, yeah. You put a word in there that was really difficult when you said dispel. That's a heavy lift.
No pressure. Just fix that for us, brother.
Yeah. Clear communication and critical thinking. If we can get one or the other, that'll help. If we have neither, we have big problems. And we didn't have clear communication from the federal government for sure. And then, it degenerated from there, in my view, the quality of it. And then in terms of critical thinking. So I don't know if it was Jesse Jackson that coined this phrase or not, but that's who I attribute it to. He said, just because I'm paranoid doesn't mean nobody's following me. And my point is that there's absolute, irrefutable, undeniable reason to be wary and to raise an eyebrow at systems. I don't even think that we need to qualify that, whether it's from Native American, Hispanic, Latino, Black, Asian, poor white, to be wary. But at the same time, so Tuskegee is a good example because there's nuance. So there was a thing called the Tuskegee experiment sometime in the 1930s-ish. I'm going to be slightly imprecise. But that was one of the things that was lifted up as why we can't do it, because we were infected with syphilis back then. And so whoever says that has gone too far. They got a piece of information. Yes, there was something bad that happened by way of the government. One, so that's the truth, but it was not an infecting that took place. It was people that the government pretended they were treating and did not. It was a withholding of treatment. So it was bad information. And so on the one hand, don't trust the government or double check or be a critical thinker with your information because this happened. But then on the other hand, don't do the same thing that offends you or offends us and be inaccurate with our passing on of information. They infected Black men with syphilis. That's not accurate. And so that's that critical thinking part. And it's tough. I can mostly speak for the Black community because that's where I come from. We love a good conspiracy. And if we have to dig a little bit, but not a lot to find it, that's even better. But if we're offended by inaccurate information from others, from the government, then let us not commit the same offense by passing on inaccurate information. And I think that just happened too often and too easily. And of course, social media and all its distribution channels, is tough to beat all that information flying all over the place, memes, articles, experts. It's just tough.
A lot of noise on the frequency, a lot of static on the frequency.
Yeah, and then unclear. And then if you don't have a person or persons, certainly a federal government and president, that you can be confident, reasonably confident, in the information, then it's a free for all, and that's where we found ourselves.
Yeah, thanks.
Yeah.
Anybody else want to jump in with any examples? Go ahead, Dr.
Yeah.
Hill.
I'm happy to. So, again, speaking from, the African Americans in the history with science, for me as a vaccine, when we were in the testing phase and the vaccine was being developed, there was a lot of, in addition to talking about the Tuskegee study, a lot of references to the life of Henrietta Lacks and her story. And for those of you joining us who don't know, Henrietta was an African-American woman who had gone to Johns Hopkins for treatment for, I believe it was cervical cancer. And during the course of her treatment, without her consent or knowledge, parts of her cells were taken and kept, and ultimately became what we now know as HeLa cells. And, so this was, I'm going to be inaccurate too, 1950, early 50s. And she ultimately passed away from her cervical cancer, but her family had no knowledge that her cells had been taken, or that essentially, we think of her as like the mother of modern science, because her cells were able to live past her. And a lot of the information that we have in modern technology and within science, a lot of people can draw on the work that was done on HeLa cells. And so again, this idea of, experimentation without consent and what happens to this kind of also clouded the conversations about, the vaccine, its safety, its efficacy, how was it developed? And then also, it was developed so quickly, but actually, not paying attention or not really understanding that research had been worked on since the technology behind the vaccine. Researchers have been working on that since the 80s to actually have it ready to go. And, the amount of effort, if you look at manpower and man hours, there was little research being done in healthcare during the time that the vaccine was done. That was not on that vaccine. So, that's what would normally have taken years was just condensed in the amount of manpower that it took to develop that. But as we think about, we actually had, I believe it was the granddaughter of Henrietta Lacks in Milwaukee talking about her grandmother's experience, her family's experience, and yet still saying that vaccination was important. Her family supported medical research despite their very complicated history with this, that this was what was right. And so again, I think people were very, inclined to believe that the negative of it. But even when someone who I would say has every right to have, to feel some kind of way about medical technology, they were very publicly advocating for communities of color to get vaccinated. So I think that's and that's part of the struggle, right? Is that we can't, Henrietta Lacks, Tuskegee, but before that, the African American history with slavery and lynching. And we can even talk about, while COVID was happening, we were also going through the Black Lives Matter. And that's another insult on African Americans. And so, I'm going to let Dr. Mayer talk about our Native populations, but, would love to revisit that in terms of how did we get to this kind of the overlap of the COVID-19 pandemic and Black Lives Matter and what that meant for communities of color.
Yeah, and Dr. Mayer, as you get your thoughts tuned up, it's really interesting that, number one, we have to acknowledge that researchers, which means places like Marquette, universities, are institutions that people have come to distrust as a result. So we've got our own set of responsibilities that are ongoing. This is not something that goes away. It's not like one day we're going to be trusted. This is an ongoing process. And yet, anytime I visit a medical facility, medical technology is remarkable, and so if I have my phone in my hand and I believe in that technology, I'm going to also believe in medical technology too, because we see what it does on a regular basis. That's not to say we don't have those concerns, because you all are absolutely correct. Those historical injustices inform so much of our challenges today. But boy, medical technology is literally saving lives every single moment of our day. Dr. Mayer, go ahead and jump in if you want to add some more.
Yeah, I'll try and wrap in both here, a little bit of the history, just to touch on a couple things for the Native community, but then also to speak to the vaccine and the way these technologies are developed, and then the question of our institutions. Just a couple thoughts. First, when again connecting with these histories that we sometimes know about, that our communities maybe know about best, and we don't get fully educated. When I think about sort of our educational system and how we talk about race and our histories, the history of white supremacy in the country, and naming these things, there are certainly many instances we could point to in the Native community regarding these connections that don't get taught. So for instance, the biggest one that comes to mind for me is the investigation done in 1976 on the sterilization of Native women through Indian Health Services. When Congress was alerted to the idea that Native women were being sterilized without their knowledge and against their wishes. Okay, so a woman would go in, perhaps she would be having a baby, she would have that baby and then wouldn't realize or know until later that within that, procedure, she had been sterilized and then couldn't have more children. When Congress investigated, I think it was through like 1973 through 1976. They did not go further back, and they said, yep, this happened, but didn't fully investigate. So to this day, we don't know how extensive that was. There were these kinds of sterilizations going on with Native women just in Canada a few years ago. I think 2016 or 2017, those reports came out. And so, as with the African American community, the Native community also has these specific instances, but then also the broader history. When we think of Native people and this connection to disease and being sort of statistically categorized as more likely to have diabetes, more likely to you can just kind of run down the numbers there, and in this case, COVID as well, COVID deaths. I think, the connections we need to make with that aren't always made when we simplify things. If we go back and look at, for instance, the 1918-1919 flu epidemic and how that disproportionately affected, as far as the rates go, population rates, Native people. You have a people who had been through huge displacements, removal from homelands, put onto reservations, lots of starvation and malnutrition. These things, we know now, trauma. All these factors are a recipe for someone to be more susceptible to disease. And yet at that time particularly, and I think sometimes even now we fall into reading these things this way, it would have been, Native people are especially vulnerable to disease. Okay, and that we really need to caution against. It really is these socio-historical political factors and these key pieces of access of information that affect our population. So with that, I just want to say, coming to, some of the mistrust, the conspiracy theories, someone coming from the humanities, I'm looking at this as, what are the stories we're telling? Where are we telling these stories? We are now engaged in social media where anybody can come on and suggest anything, and we have this sort of dispersal of authority. We have folks in authority who, we mistrust, and that's a recipe too. I would also say that, we can talk about health disparities, but we need to talk about the links, the disparities in education. As someone who every day teaches students how to do research, how to assess a source, even within my family and friends, I found myself saying, okay, you're sending me this article that says vaccines are dangerous. And when I'm looking at it, I'm seeing how it's not sourced well. We need a population who knows how to read these things and do that critical thinking piece. And I have to say, I think, this is an education piece as much as it is a healthcare piece. So those are a couple. I know I have more thoughts, but
we're gonna do a couple things. We're gonna show a short video here in just a second, and then we're gonna start to wrap up our panel, and then get some questions from folks who are viewing online with us. And we're gonna get into that wrap-up question will include what are some of these other challenges that are out there that we need to be considering, because COVID is just but one of those issues. You mentioned comorbidities. And then also we want to think about where we can be successful moving forward. We don't want to leave this conversation without making sure we've talked about some of those strategies, which is where the video will help us get into that conversation. But I do want to share one story, and I'm going to get in trouble by sharing this story, but it's I just have to. So my aunt, she's about 70 years old, beautiful woman, love her. Love you, Auntie. I was having a conversation with her about getting vaccinated, and she said, well, no, I can't, nephew, And I said, well, why not? She age, and she talked about some other stuff. And then she said, and plus I saw this TikTok video. And I said, Auntie, what are you doing on TikTok? First of all. Everything I know about wellness, drinking water, gut health. She was instrumental in, talking to me about skin and about the vaccine. It was really, really surprising, because I owe a lot of my own wellness strategies that she was teaching me when I was a teenager. I didn't even realize how far ahead she was on some of this stuff. It just speaks to the challenges. So here's what we're going to do next. Jorge's going to cue up a video for us that gives us a quick overview of the work that's being done in the MKE Black Grassroots Network for Health Equity. And then we're going to come back to our panelists for some wrap-up comments on where we're headed, some of these other strategies and the like. And then we're going to go to Q&A. Folks who are listening, we have a plan to wrap up at about 1:30 or so. We know we're extending over the hour that is customarily set aside for these conversations. But in order to get to that history, we just needed a little bit more time. We hope you can stay with us. Don't worry, though, if you can't, this is being recorded. You can come back and check on some of this later. Or, hey, why don't you go ahead and get that video queued up for us, and then we'll begin to wrap up after we check it out.
There's a lot of things that we have addressed. The pandemic really pushed all of that to the top.
So the COVID pandemic has impacted me in my life as a mother, as a business owner, as just a Black woman trying to make it happen every day, and keeping my business open and my child in school.
I think I started out at the beginning of the pandemic, talking with a variety of our teammates, and we were looking to do some work on the ground and to get some funding for the ground, because we knew that the systems that should be in place and being effective in serving community were not. Health equity is about how our community or how our society is structured with opportunities so that everyone can lead a life and really experience their maximum and optimal health potential.
Health equity means to me that we have achieved a society in which everyone, regardless of their social circumstances, their social group membership, can live to their absolute full, realize their fullest potential and thrive.
It's my life's work. It's the whole reason why I do the work that I do. Opening Health Connections Incorporated specifically was to fill gaps in the ecosystem of healthcare delivery in Milwaukee. And so health equity and achieving healthcare access and equity is just at the base and at the core of every decision I make as far as business is concerned. So it's everything.
I look at it as a way of treating people through humanity. When you begin to really treat people the way they should be in every aspect, whether it's economically, mentally, medically, every aspect of it, that brings equity, because when you treat people with humanity, you don't see the differences. You see them as one.
Important for moving things forward is to have a common agenda, to have a critical mass of people on the same page so we know where we're headed. And often we hear people call out for that. What's the agenda? What's the community's agenda?
The community change agenda is a document formulated out of a conversation that we had as the MKE Black Grassroots Network to figure out what are the priorities for Black Milwaukee. What are the things that we consider the most important, that we should focus on, that we should put investment into, and that we should present to the community as a plan. We have a very specific problem here with racism, with oppressive systems and things of this nature, and those are conversations of liberation. How do we get out of that? How do we beat those systems? How do we change those systems?
The elevation and prioritization of Blacks in the city and county of Milwaukee takes center stage in the community change agenda.
A community change agenda calls for big policy change and systemic change to address the underlying structural drivers of social and health inequities in Milwaukee.
Things as it relates to the Black community on several levels: social justice, healing justice, system change, Black liberation, and also allowing things to be addressed through the Black lens.
They see this as a priority. This is something that really engages their being, and then ask the questions: how can I plug into this agenda? How can I learn more about this agenda? Certainly coming out to our event and learning about it will create other opportunities.
It is important for Black families and communities to embrace this change agenda because, one, again, we have to do something different than what we have been doing.
It's important for the families and community of Milwaukee to embrace the community change agenda because it's the map by which we need to move forward. We must do this together. We must do this in a way where we use all of our talents together, and that when you come to the table, you understand, like, what are we looking for, what are we going, and so you can see it because it's already laid out so beautifully for you.
We need to hear what you need in your community, what resources, what are the needs of your family and businesses in that community in order for us to thrive.
That's great stuff. Thank you very much. Thank you very much. Let's offer each of you the opportunity to offer some parting comments, and then we'll get into some Q&A. For you folks who are joining us, you'll be able to submit your questions, and Jorge will send it over to us, and the panelists will respond accordingly. But as we wrap up, let's think about a two-pronged question. What are some of those other issues still out there? Some of those health-related concerns that we have to remain mindful about? And then what are some of the important responses that you all are familiar with or are taking part in some ways that we need to be aware of so that we have just a little bit more hope moving forward. Pastor Lanier, can you start us off with this, and then Dr. Mayer, we'll go to you, and Dr. Keller, we'll ask you to close out this portion for us. But what's still out there? What's still on the horizon? And also, what are we doing that we really want to be proud of and amplify? And if you want to say a little bit more about the network, please do so.
Yeah, you know, on the what's still out there, the
Right.
list is long, tragically long. You know, first of all, COVID's not gone. You know, Erica Sinclair and many others would say it, but you know, coronavirus is still here. It hasn't gone anywhere. Don't get lax, don't relax, despite the desire to do so. But other issues we're still dealing and have not fully addressed: lead poisoning, lead in the water. We are having a significant outbreak of violence. Challenges with our education system, as Samantha said, that's not explicit but implicitly connected to health issues. We still have maternal health issues in the city. We still have infant mortality issues. And so I'll stop there. It's not a short list. In the city that's the most segregated in the nation, it's actually predictable. I think what I'll talk about in terms of opportunities and hope is, as you saw the video of the Black Grassroots Health Network, and it's one of several efforts around the city. The thing about Milwaukee is rich in talent and potential and people doing great work, but it's so segmented and segregated. But if you pay attention, for example, this particular Black Grassroots Health, Black Equity Grassroots Health Network grew up from the ground up, but it was a connection of the ground, health, and fundraisers. So I was connected to it from Lisa Jones, who's the lead organizer from MICA. And Lisa Jones was having conversations with Dr. Lorraine Halinka-Malco, who's in the School of Public Health for UWM. And then also connected to Zilber, who ultimately provided the funding. And then I was part of this team with Jeff and Quentin, and later on Erica, that was doing this ground up, looking at the community, saying, we've got gaps. It doesn't appear there's anybody filling them. So from the ground, let us organize, let us mobilize. And we went to get funding from Zilber, did not get it the first time around. We pushed back on them a little bit and said, you're looking through a particular lens that is not reflective of the reality of the ground in the moment. And they were very receptive to us dialoguing further and said, okay, we'll fund this thing, and it's born this rich fruit. And so, Rob, to answer your question, we have a lot of what we need in community: talent, vision, ideas, passion, commitment, persistence. Our segregated state and the racist history keeps a lid sometimes on that talent, or lacks the capacity or the will to bring things together. And so the talent is there and it's emerging. We see leadership, diverse leadership bubbling up now. The leadership has already been there. The climate for change and the organized push needed to make a difference. So I'm glad to see all this talent. You know, you're the only one on the screen that I've worked with before. And so here's all this talent right in front of me. So it's here. We've got the talent. We've got the minds. We've got the experience. We need to mobilize and organize and assume some leadership positions. I was going to say push leadership. You know, hopefully sometimes leadership will do what it needs to do. And sometimes you got to grab the reins of leadership and make some things happen. So those are my parting thoughts.
Thank you so very much. Dr. Mayer.
Let's see, I don't want to say too much here, just in closing, just I'm in awe of the work you all are doing and that we saw in the video, and very necessary work. For me, just to, you know, bringing it home for me, it was, I'm from Minneapolis, and I was actually just showing a video in class today connected to a novel that was on the jingle dress, Ojibwe jingle dress and history. And part of that was showing jingle dress dancers dancing for community, but then also in connection with the murder of George Floyd and Native people dancing in what is now known as George Floyd Square in Minnesota, and which is right in or near the Native corridor in the city. And to me, all of these issues, including policing, but also education, health, are connected. And this is a moment where in crisis, the COVID-19 crisis, we're seeing the work yet to be done across our communities in stark relief. And there is a lot. That list, it can feel heavy. I'm excited to see our communities, our Black, Indigenous, people of color communities, not let this go. Things need to be changed, and we need to do it together and in our respective communities. And I just am happy to learn about the work that's going on and be part of the small part of the conversation here. But but thank you.
Thank you very much, Dr. Mayer. Dr. Keller.
Thank you. Yeah, so I think at the end of the day, one of the key things that we have to keep in mind is that the COVID-19 pandemic, it exacerbated disparities that were already in existence. And as we think about, what is our path forward, I don't see a path forward that will be effective for eliminating those disparities if we don't address the underlying root causes. And so that really means thinking about how do we address communities that have been disproportionately burdened by societal factors. And those are things like my colleagues have mentioned: low education, poverty. Growing up in poverty, doesn't matter what your skin color is, it's bad for your health. And so there really needs to be a concerted effort to address that. And as we think about moving forward from COVID-19, let's not make the mistake of thinking that we can just go back to where things were pre-COVID. That will not work. We need to continue to address things like food insecurity, having emergency rental assistance as we're seeing the number of evictions rise in our city as those moratoriums have ended, having emergency housing vouchers for families. And in the workplace, we need to think about what our sick policies are for people, that they can take time off from work when they are ill, not only to protect themselves, but to protect the workplace. Especially thinking about those people who are immunocompromised. I think about the sickle cell population within the African American communities. Like, we need to do things to help to provide care for them. And Rob, you mentioned this earlier, but chronic diseases did not go away during COVID. And so we look at what continues to kill our Native populations, our African American populations, continues to be heart disease and cancer. And those things are because we've been disproportionately burdened by poverty, lack of access to fresh fruits and vegetables and water, not just like having it available in our communities, but having the resources to be able to afford them. And so those are the things that we have to work on. And, I will say that the work that, so one of the organizations that I work with is Near West Side Partners, and we've taken a place-based approach. So working with the 7 neighborhoods that make up the Near West Side and really thinking about how do we do this work within this place. And so one of the things that we did is, we spent some time with the residents and really asked them to help us think through 2 questions. How do we make the Near West Side a healthier community? And how do we make this a great place to live, work, play, and stay? And how we're moving forward is using those items as our action items to guide the work that we do within these neighborhoods. So not just, I'm a researcher at Marquette, I do community engaged work, but that means that we are working with residents to address the problems that are a priority to them in a way that is acceptable and meaningful to them. So not what, we're coming and saying, but how the community wants to do that. And I will, thinking about leaving on a place of hope. So we talked about distrust between communities and institutions. I do want to point out that, we are starting to see changes in this, in that institutions are recognizing, as Pastor Lanier mentioned, that the talent already exists in communities. The relationships already exist in the community. And what may just be needed is external funding to allow these things to rise. And sometimes it's just for institutions to get out of the way of the community and let them do what they see fit. And so, even with COVID, we did see that the Wisconsin Department of Health Services, they awarded close to $18 million in grants to about 150 community organizations throughout the state of Wisconsin as part of their approach to addressing COVID-19 vaccination rates. And so they provided funding for these organizations to engage with their community that already trusted them in a way that was acceptable and meaningful for that community. And I'm hoping that as we move forward to tackle some of these underlying root cause issues, that we'll continue to see government step in that way, recognizing the talent that already exists in communities.
Thank you all so very much. And I'm going to thank you one more time when we actually conclude. This wraps up the panel portion of our talk today, of our conversation here. And now we want to get a little bit of Q&A from the folks who've been joining us there on YouTube and in the virtual world. Jorge has a few questions that we've teed up for our panelists. And Jorge, you want to jump in with those for us?
Yeah, so we have a few questions on YouTube. Stephen Torres has a couple of contributions in terms of the historical inequalities of medicalization, or historical injustices of medicalization. He says Puerto Ricans in the 1930s, Cornelius P. Rhodes injecting cancer cells. He also says the Puerto Rican pill trials. And he has a question. He says, are there any efforts to help address some socioeconomic issues first so vaccines can be a conversation? So perhaps we can start with that question.
Anybody want to try to grapple with that one?
I appreciate that question because I think it brings up a really important point when we think about we talk about access, and we often think about it in terms of, well, if we have vaccines available in a community, people will get vaccinated, but that misses the point that there's an opportunity cost for vaccination. So whether it's a time away from work, if you have, some people did experience some mild discomfort after being vaccinated that might have prevented them from being able to work or take care of their children. Those are opportunity costs. And so when we think about what does it mean to make vaccination accessible, we have to address all of those things. So as far as how we're addressing it, I know in some of the community organizations, there really has been thinking about, okay, how do we provide childcare so people can come, changing up the times, meeting people where they are, those things. I know some community organizations have given free meals out, so that if you come get your vaccine, you don't have to worry about cooking dinner tonight. Here is providing that meal. So those are some of the things that I've seen. And again, that comes from, I think, having an understanding of the community that you're working with and what their needs are. But I'll let my other colleagues comment as well.
All right, or hey, you got another question? Oh, Walt, you gonna jump in on that one, or do you want to go to another question?
I'll just add briefly in terms of solutions and places. I mentioned I serve on Milwaukee Health Services Inc.'s board. Dr. Mayer mentioned Gerald Ignace. And so if people are not familiar with the community health centers or the federally qualified health centers, I would really encourage you to become familiar with those spaces, because these are organizations that serve community, that are accustomed to serving the community, that know their communities well, know and are charged with meeting communities where they are. They really provide a great service and are not always well known. So systemically, that's a great place to start. Look at your FQHCs, again, Milwaukee Health Services, Ignace, 16th Street. There are others. That's just a good place for both service and system.
And to that list, I would also add progressive health centers, as they are located right here in community as well.
I did not mean to leave them out. Community outreach too.
That's great. I love it. I love it. That's Walt and I talk a lot about ecosystems, and when you start to look at the ecosystem, you realize there's plenty of resources out there. Or hey, you got another one for us?
Sure. Benjamin Porter says, I'm curious to hear thoughts on what accountability and reparations would look like within the health sector to address these histories of inequalities and injustices.
Ooh, what would it look like? Reparations in terms of health injustice. Go ahead, Walt.
Yeah, real brief. I just saw it today. I was going to pop it in the chat. I think it was today. I just saw it today. Harvard has just allocated $100 million to redress their participation in slavery. So that's a nice, healthy dollar amount. And of course, people need to be at the table to make sure it's dispatched appropriately. But there are some examples that are happening right now of institutions and a few organizations that are making those, setting aside those dollars. And so precedents have been set in particular areas. We need to continue to follow them.
And although my response isn't reparations specific, this is really just, basic citizenship rights with our gross and violent cuts to public education that then made it such that we couldn't afford to have nurses in the school or have any sort of medical support in the school. Imagine how useful having some sort of public health expertise in our schools would have been over the last couple of years, and then of course, access to access to effective mental health care.
Oh,
yeah. And maybe that's the fourth installment that we have to then bring that mental health conversation back into view in reference to COVID and moving forward. And so I think that there are, even before we get to reparations, there are some very clear political decisions and choices that have been made in the very recent past that continue to injure not only our most vulnerable populations, but children who through this COVID thing, we were given this notion that kids were somehow superheroes in the face of COVID, they'll be fine. Like, no, and we knew that we learned very quickly how wrong that was. Even before we get to reparations, let's just make sure that we have some basic rights of citizenship addressing these issues. Others?
I think, in addition to that, one of the things that I think those of us that are involved in training future clinicians that we work at is redefining health. And I think that, in our country, we tend to think about health as what happens within that very finite healthcare system. And so what would it look like if our nurses, our physician assistants, our nurse practitioners, our doctors was equally concerned about your access to food, the safety of your environment, access to high quality education, clean water, stable housing, if they were equally as concerned about that as they were about your blood pressure or your broken arm. And so I think if we can get to a place like that, then, and our European counterparts are doing it, right? They're investing a significant amount more in social services as they're in the healthcare system, and they're living longer than we are. So I think there's lessons to be learned about what does it mean to be healthy and what does it mean to produce health?
Shall we move to another question?
I just want to add
Go
briefly.
ahead, Dr. Mayer. Yeah.
Just very briefly, I will say, and it's sort of a similar response here, in that we are also seeing in the Native community lots of moves to, there's sort of the hashtag land back movement, where we're actually seeing tribes buy back land, and then certain entities raising money and giving land back to tribes. I think for always my answer to this kind of thing. And it's interesting that we're in some ways answering about particular healthcare, but then also about these historical injustices. To address the acute, you need to address, the larger issue. And so for Native people, it's honoring the treaties, honor the agreements, the original agreements, or give the land back. And I think the same argument for reparations. It's interesting to see private entities and maybe some states work on these initiatives. I don't know if piecemeal is the best way to go, but that seems to be the way things are going right now. We'll see if we can address this more broadly.
Let's maybe do one more. We're about 5 minutes out. Let these folks get a break here.
We have John Smith has several questions, actually, so perhaps I can read them all at once and we just address them in any order you want. So one of the questions is, how do you connect with white leaders who are good people, but their decisions about resources and strategies are harmful? His second question is, what strategies are the most effective towards improving health outcomes among Black, Indigenous, and people of color and other marginalized populations? And last question, can you talk about nursing shortage and what can be some in Milwaukee? What can be some in Milwaukee to increase the healthcare workforce? So those are some of John Smith's questions.
We'll let each panelist take their turn at either of those that you feel like you can address.
The best way is I'm going to answer question number 2 first. I can't answer the nursing one. And I'm going to be repetitious as an educator in terms of best ways to connecting with systems and advancing system work. I really believe in the federally qualified health centers. And it's not just because I sit on the board, but we're talking about systemic failures. We're talking about systemic racism. And so you have to have system to match system. And the strongest system that I see right now that is completely aligned with serving community in culturally relevant and appropriate ways, that has authentic relationship with its customers, clients, patients. It really is those health centers that I mentioned before, that's a good place to plug into a pre-existing organization and its institutional power, resources, and knowledge. So that's question number 2. Question number 1, it was how do you identify or work with white leaders? I think I would say this thing, and it may be Milwaukee centric, is I'll use a chess metaphor. Whatever you do in Milwaukee, as you're advocating or pushing, you have to push all the way through until the end. We're dealing with systemic mediocrity, systemic intentional malice, systemic laziness. And so it's not sufficient to put good information into the marketplace. That's good. That's helpful. It's not sufficient to advocate. That's good. But my experience, I'm 54, I'll be 55 soon, been a professional here for 20 years, is you have to push all the way until you get the result that you want. It's not satisfactory to surface the information. It's not satisfactory to point out bad actors. If you have this type of stamina to do that, or your team or your organization, you got to push all the way through to the end, because systemically, they falls back to the norm. It's like pushing that rock up the hill. Push the rock up the hill, take a break, put something in front of it, keep it there, and keep on pushing. But if you stop, these systems go back to the norm of mediocrity and apathy. I'm not even naming individuals. It is systemic. So my point is, meet with the white allies, but continue pushing until you get a result that you want.
Any other folks? Go ahead, Dr. Mayer.
Just briefly and maybe oddly address the nursing shortage. This isn't my field, so I'm just, adding on here. As with teachers and other types of professions, I see in the medical field what they've been through in the past 2 years. And we need to value people in these fields and value science, value the work that people do. And I really see our undervaluing of these areas and our own health in that way as the big problem. So it's not really a good, policy idea here or anything like that, but I really see our issues in education connected to this. And again, that broader story that we're telling about ourselves and our communities and how they interact with each other. There's a lot of real discouraging devaluing of these very, very people who do very important work. And so that needs to flip back around if we're going to get anywhere.
So I will just add on to the nursing shortage. And, I absolutely agree that, working in the College of Nursing with people who are still working at the bedside and the stories and supporting our students as they train in this profession. And there is a need to continue to support the work that they're doing every day. And that's part of the messaging about why is it important for communities to be vaccinated is so that we can decrease the load on our healthcare system, right? So if it's not for you, but that's one less person that is engaging with the healthcare system, that it gives our medical professionals a fighting chance of staying ahead of the disease. The other thing that I think is really important is to support K-12 education. If we want to increase the number of people that are entering the medical field and the science field, it has to start with supporting students in STEAM education, K through 12. And so we really need to be educated and advocating for supporting our schools, supporting community schools. Every child should have the opportunity for high quality education, regardless of what zip code they live in.
And that indeed is a human right. If I may, Walter, Samantha, Abiola, and let's not forget Erica, thank you all so very much. We can't emphasize how important it is to connect the past with the present and then also be forward thinking along the way. Jorge, thank you for all your support. For those folks who joined us virtually, we appreciate it. This will be recorded and available for you. Just want to leave with one more thought. Hope is a choice, ladies and gentlemen. Hope is a choice. And the way that we fuel that hope is through purposeful, human-centered action. Thank you for joining us today on behalf of the Center for the Advancement of the Humanities, Center for Urban Research, Teaching and Outreach, Institute for Systems Change and Peace Building, and the MKE Black Grassroots Network for Health Equity. Folks, look forward to a fourth installment in a couple of months over the summer. We will continue to have these conversations. We thank you for joining us today, and we thank our panelists.